Welcome back to another Explainer. I am so incredibly excited to take you on what's essentially a medical detective journey today. We're going to explore the absolutely amazing and, honestly, sometimes terrifying ways our bodies function at a microscopic level. Just think about this for a second. A single missing enzyme, just one tiny defective protein in a sprawling metabolic pathway can cause absolute systemic chaos. Today, we're decoding these invisible blockades and we're going to learn exactly how to spot them before the real damage is done. To get our gears turning right off the bat, I want you to picture something. Imagine a disease where a patient's urine turns pitch black just from sitting in the toilet bowl. I mean, what on earth could be the culprit? It sounds like something straight out of a science fiction novel, right? But this fascinating, kind of shocking physical symptom is actually a real, classic hallmark of a metabolic defect. You see, invisible biochemical traffic jams inside the body often create these really stark, highly visible clues on the outside. By the end of this explainer, you're going to know exactly what causes this, plus a whole lot more.
All right, let's map out our diagnostic roadmap for today. We're covering 1. The concept of the metabolic blockade, 2. PKU and phenylalanine accumulation, 3. A showdown between homocystinuria and Marfan syndrome, 4. Alkaptonuria, that's our black urine mystery, and 5. Urea cycle defect crises. Let's get right to it.
Section 1. The metabolic blockade. Missing enzymes causing systemic chaos. Let's set up the foundational biochemistry we're going to need.
Before we dive into the specific diseases, we really need to know what we're actually looking at. We're dealing with what's called an amino acidopathy. This is a disorder where the parent amino acid itself accumulates in the blood. Think of it like a factory assembly line. If the worker who usually takes part A and turns it into part B goes missing, well, part A is just going to pile up. This is critically different from organic acidemias, where it's actually the downstream catabolic products that are building up. For our purposes today, we are hunting down those parent amino acids.
Moving right along to Section 2, PKU, or phenylalanine accumulation, also known as the case of the mousy odor.
Meet our first suspect, phenylketonuria, or PKU. It's caused by a missing PAH enzyme. Without it, the amino acid phenylalanine literally has nowhere to go. It just builds up and builds up. And the mechanism of harm here is multi-layered. This massive excess of phenylalanine physically blocks other essential amino acids from getting into the brain, which completely derails how we make neurotransmitters. It also stops myelin synthesis, essentially stripping the protective coating right off our nerves. But what I really want you to remember are the vivid sensory clues. It competitively inhibits an enzyme called tyrosinase, which halts melanin production. This leads to very noticeable hypopigmentation, meaning the patient will have lighter skin and hair than the rest of their family. Plus, because the body is desperately trying to dump this excess down an alternate pathway, it creates something called phenylacetate, and that gives the patient's skin, hair, and urine a distinct, very noticeable, mousy odor.
Now, when you compare an untreated patient with a treated patient, the contrast is absolutely stark. This right here is exactly why newborn screening is a literal game changer. If we miss PKU, the patient fails to meet developmental milestones, develops microcephaly, and suffers from severe, irreversible intellectual disability. But if we catch this via a simple newborn blood spot and start dietary treatment before they are 2 weeks old, development and intellect are completely normal. Catching this invisible defect within the first 14 days of life makes all the difference in the world.
So how do we treat it? It mostly revolves around a super strict low phenylalanine diet, while also supplementing tyrosine, which actually becomes an essential amino acid since the body can't make it anymore. We also have therapies like BH4, which is the enzyme's essential cofactor, and even a newer injectable enzyme called PEG-valiase. But, okay, let me pause here because I need to shift gears and emphasize a really critical clinical pearl: maternal PKU. If a mother with PKU has high phenylalanine levels during pregnancy, it acts as a severe teratogen. It will cause major congenital defects, microcephaly, and intellectual disability in the fetus, even if the baby didn't inherit PKU itself. Strict dietary control absolutely must begin at least 2 months before conception. It is absolutely vital.
Let's jump to Section 3, homocystinuria versus Marfan syndrome, a classic tale of two connective tissue disorders.
What's really fascinating about homocystinuria is that it's kind of a master of disguise. It perfectly mimics Marfan syndrome. It's caused by a CBS enzyme deficiency, and the systemic damage hits 4 main bodily systems. In the eyes, it causes ectopia lentis, that's lens dislocation.
Skeletally, patients develop what's called a marfanoid habitus, meaning they're unusually tall with really long, thin limbs. In the central nervous system, roughly 50% of patients have some level of intellectual disability. But the most critical system affected here, vascular. Sky-high homocysteine absolutely destroys the endothelium. This makes thromboembolism, major blood clots in the heart, brain, or kidneys, a massive risk. In fact, it's the major cause of death, tragically sometimes even in the very first decade of life.
Since both conditions present with these tall, lanky bodies and dislocated lenses, you've got to know how to tell them apart. It's a classic medical differential showdown. The golden rule you need to lock into memory right now: the lens dislocation. In homocystinuria, the lens typically dislocates downward, but in Marfan syndrome, it dislocates upward. On top of that, homocystinuria is recessive, comes with intellectual disability and life-threatening thrombosis. Marfan, on the other hand, is dominant, intellect is usually normal, and their major vascular threat is aortic dilation, not clotting. So remember, downward versus upward. For sure don't forget that one.
Now, say you've diagnosed a homocystinuria. You still need to figure out exactly which enzyme pathway is broken. Classic CBS deficiency blocks the downward pathway. That means both homocysteine and its precursor, methionine, back up and show high levels on a lab test. But what if the defect is in the remethylation pathway? Well, then homocysteine can't recycle back into methionine. So you end up with high homocysteine but low methionine. Spotting that low methionine on a plasma amino acid panel, that is the ultimate key to solving this specific biochemical mystery.
Moving right into Section 4, alkaptonuria, the black urine and the slow buildup of homogentacetic acid.
Remember that mystery I pitched you at the very beginning? Well, here is your culprit. In alkaptonuria, the homogentasic acid oxidase enzyme is missing, so homogentasic acid accumulates. When it gets excreted in the urine and hits the air or the alkali in a toilet bowl, it oxidizes into a dark, pitch-black polymer. It is totally pathognomonic. The clinical presentation gives us the classic BOA triad: black urine, ochronosis, and arthritis. Ochronosis is this buildup of a gray-brown pigment in the connective tissues, and you can actually see it in the whites of a patient's eyes or in their ear cartilage. To protect their joints, we use a clever drug called nitacinone. It basically inhibits an enzyme further upstream, stopping that toxic acid from ever being made in the first place.
Let's track how this unfolds over a patient's lifetime, because this blocked pathway creates a really slow, cascading disaster. The black urine? That's there from infancy, but the physical damage is microscopic at first. By the time the patient hits their 30s or 40s, all that pigment deposition starts causing severe lower back pain. Fast forward to their 40s and 50s, and large joints, like the hips and knees, are being destroyed by arthritis. And by their 60s, that exact same pigment has stiffened the heart valves, causing aortic stenosis. It's a disease that literally takes decades to fully reveal itself.
For our final section, we're shifting the pace completely. Section 5, Urea Cycle Defect Crises, the high-stakes emergency of hyperammonemia.
What happens when the body's toxic ammonia disposal system just completely shuts down? The answer is sudden, absolutely terrifying crises. The urea cycle is supposed to turn toxic ammonia into harmless urea. Take that away, and ammonia just floods the brain. In neonates with a complete absence of the enzyme, they progress from lethargy to a coma and death within days. But check out the milder, partial variants. These can hide for years. They often get misdiagnosed as chronic fatigue, weird GI issues, or even mood swings. A female carrier of OTC deficiency might suddenly fall into a coma during the massive catabolic stress of childbirth. And listen to this: giving corticosteroids or chemotherapy to an undiagnosed patient can trigger a sudden, fatal hyperammonemic crisis. It's literally an invisible tripwire in their metabolism.
So if you're dealing with a urea cycle defect, you must memorize this crucial rule. Seriously, write this down. OTC deficiency is the only X-linked urea cycle defect, and it is the only one with elevated urine orotic acid. All the other defects? Autosomal recessive, and their orotic acid levels are normal or low. Because the OTC enzyme is blocked, the molecule right before it, carbamyl phosphate, overflows into a completely different pathway, which generates huge amounts of orotic acid in the urine. That right there is your ultimate diagnostic differentiator. Okay, a patient is crashing with sky-high ammonia. How do we save them? Here is the acute emergency protocol.
Step 1. Stop catabolism. We push IV glucose and lipids so the body stops breaking down its own protein, because breaking down protein just generates more ammonia. Step 2 is this absolutely brilliant biological workaround. We give IV nitrogen scavengers like phenylacetate and benzoate. These drugs completely bypass the broken urea cycle. They bind directly to amino acids in the blood, form water-soluble compounds, and the patient literally pees the excess nitrogen away. Step 3. Administer arginine. It's normally made by the cycle, but right now it has become an essential amino acid.
Putting it all together, let's lock these key differences firmly into your memory. For PKU, you're looking for the PAH defect causing that mousy odor and intellectual disability. For homocystinuria, it's the CBS defect causing a downward lens dislocation and risk of fatal thrombosis. Alkaptonuria is your HGD defect, giving you the classic black urine and adult-onset arthritis. And finally, OTC deficiency is your sole X-linked urea cycle defect causing lethal hyperammonia. Take a mental snapshot of these key takeaways.
As we wrap things up today, I want to leave you with a thought. Technologies like tandem mass spectrometry now allow us to screen newborns for dozens of these invisible blockades all at once. We're preventing irreversible brain damage before it even has a chance to start. But biology is incredibly vast. With dozens of these already identifiable at birth, you gotta wonder, what other invisible microscopic defects are silently waiting out there to be discovered? And more importantly, to be cured. Keep your detective hats on, keep looking for the clues, and I'll see you in the next explainer.